Welcome everybody for the afternoon session. We're going to start in a few moments. If you're going to go back to your table. It's my pleasure to moderate this session where we're going to talk about biomarkers and clinical trials and what the future holds for PSC. It's my unique pleasure to introduce the first speaker, Dr. John Eaton from Mayo Clinic. John is a great colleague who is the assistant professor of medicine at Mayo Clinic. He's interested in the space of clinical trials and imaging for primary sclerosing cholangitis. John has worked with us in the past to develop the Presto model. He has done great work. He has been very prominent internationally to work with the groups, particularly the International PSC group, or in developing guidelines about MR and how this can be used for primary sclerosing cholangitis outcomes. He has been instrumental to the cholestatic and autoimmune liver disease interest group of the AASLD. And as I said earlier, his passion is about clinical trials and using artificial intelligence to understand how we can leverage imaging to understand better the progression of PSC. One thing that you know about John, he's a very hard worker. When he started to work with us about Presto, he didn't have glasses. And then he had to review a lot of outside records from many of you, about 32 linear feet of outside records. And so he has done a lot of great work. So John, thank you for taking the time to give us your thoughts about how to better use biomarkers for PSC. Thank you.
Thank you, Kostas, for that kind introduction. And indeed, I didn't wear glasses before that work, and I could remember Dr. Keith Linder's handwriting from some notes in 1988 very well. So I want to say again, it's a distinct pleasure and honor to be here in front of all of you speaking today. I know I speak on behalf of my colleagues that engaging with all of you leaves us with a renewed sense of vigor, hope, and optimism. And it's really energizing for us to speak with all of you as individuals and as a larger group. So I'm going to be speaking about biomarkers and imaging, and I'm going to try to make this a digestible talk and make this as applicable as I can to all of you in just kind of your routine day-to-day operations as a patient or as a caregiver, as somebody who may have PSC. So I'm going to define what this term biomarker even means, as we hear this term used frequently. I'm going to highlight what some implications of biomarkers are for individual patients, and also why it's relevant for drug development and clinical trials. And I'm going to provide you with just a sampling of some select non-radiographic biomarkers, as well as magnetic resonance imaging-based biomarkers that are used in routine clinical practice that I think is a good idea to be familiar with. And because I have the unenviable job of being the first speaker after lunch, I got to try to keep all of you awake. So what does biomarkers mean? Well, according to the FDA, simply put, it's some objective measure of normal biology or normal process, an abnormal or pathologic process, or some response to therapy. So it's some objective measurement. Why are biomarkers important for you or your loved one with PSC? Number one, they're essential for our day-to-day practice and just the routine clinical care for patients with PSC. Let me give some examples. There are a number of types of biomarkers. One example is a diagnostic biomarker, or some test that's used to diagnose an underlying condition. A great example of this would be magnetic resonance cholangiopancreatography, or MRCP, is used to diagnose PSC frequently. So that's a good example of a diagnostic biomarker. There are also a number of what we would call prognostic biomarkers, or some tests that may give us an insight into an outcome or of event that may happen down the road. And there are a number of examples of these, such as liver test or alkaline phosphatase. We heard about the MELD sodium score earlier today from Dr. Heimbach, the Presto score, which we'll highlight in a bit, and other examples. The second reason why they are important and relevant is because they are fundamentally necessary for the conduct of clinical trials and ultimately to get a medical therapy approved for PSC. Without effective biomarkers, it will be very difficult, if not impossible, to ultimately get some form of medical therapy approved for PSC to slow or halt the progression. And that's because biomarkers could be used as what are called surrogate endpoints. What are surrogate endpoints? Surrogate endpoints are a tool used in clinical trials as some substitute for a direct measurement of how a patient either feels, functions, or survives. And using a surrogate endpoint when conducting a clinical trial is very useful and often necessary when trying to study a disease that is rare and when the clinical events occur either very slowly or uncommonly. So what does this look like? So predictive biomarkers and surrogate endpoints in an ideal world, if worked properly in an ideal situation, are like a crystal ball into the future. So let's take two hypothetical groups of patients, both with PSC. The first group, or Group A, has some intervention done over time as part of a study. And at the end of that intervention, or during that intervention, some predictive biomarker is measured, and there seems to be a change in that predictive biomarker, or in this case, a change in a surrogate endpoint. Over time, that change in the surrogate endpoint also predicts and is associated with some change in a pretty hard clinical outcome, such as time to liver transplant, patient survival, et cetera. This would be an ideal way in which a surrogate endpoint or predictive biomarker would work. Contrasting that to the second group of patients who didn't have an intervention and did not have any change in that surrogate endpoint or predictive biomarker, which also meant that over time there was no change in a clinical outcome. So surrogate endpoints and predictive biomarkers give us an idea about potential responses to therapy and what may happen down the road. There's a number of examples in which this has been used in clinical practice and in clinical trials. A good example for primary biliary cholangitis would be changes in alkaline phosphatase and how a particular medicine called obeticholic acid led to changes and improvements in obeticholic acid, or it led to changes in alkaline phosphatase, which ultimately led to the approval of obeticholic acid by the FDA, with the understanding that there is going to be some post-marketing study and research to demonstrate that that drug, obeticholic acid, actually translated into improved clinical outcomes for patients with PBC. Other examples of biomarkers that are routinely used would be blood pressure, for example. Blood pressure is a biomarker for having a heart attack, stroke, or death. Blood sugar is a biomarker for having adverse outcomes for diabetes. So if a drug shows that it can improve a blood sugar, if it can show that it can improve blood pressure, that's one approach in terms of getting drugs approved for those indications. So there are a number of diagnostic and prognostic biomarkers within the realm of PSC that cover a variety of areas. This is a very hot area of research that's evolving rapidly. And generally, these biomarkers fall or assess a variety of categories such as cholestasis, which is the backup of bile flow. Good examples of that would be alkaline phosphatase, bilirubin levels, serum bile acids, and a number of other prognostic scores. Other biomarkers may assess fibrosis or scarring in the liver. Examples of that would be a liver biopsy or histology, liver stiffness as measured by elastography, which we'll touch on, and others. Cholangiogram, which is a fancy bile duct x-ray, which really gives a clear sense of what do the bile ducts look like, what do the strictures look like, can we quantify that, is it associated with prognosis, and there are a number of ways, typically MRI-based, but also ERCP-based, which may have some prognostic and diagnostic value. And then other measurements of the immune system, the degree of inflammation, which can also be potentially employed. So we're not going to cover all of that. We're just going to cover a few select topics which I think are relevant and more pertinent to kind of a day-to-day practice. And so I'm going to start by talking about alkaline phosphatase. This is one of the liver tests, which I'm sure all of you are familiar with. It's actually an enzyme that can be found in multiple different organs, in addition to the bile ducts lining the liver. In PSC, having a normal alkaline phosphatase or an alkaline phosphatase that's less than 1.5 times the upper limit of normal has been associated with improved outcomes. There's been a number of studies which have looked at this retrospectively, One example illustrated that after about 7 years, about 15% of individuals with a normal alkaline phosphatase compared to 35% with an abnormal alkaline phosphatase developed some serious PSC-related complication. Now, there's probably a couple ways of looking at this. You would be correct in saying, wow, if you have an abnormal alkaline phosphatase, you're 2 times more likely to develop a PSC-related complication. That wouldn't be incorrect. The way I would look at this is, wow, almost 70% of people with an abnormal alkaline phosphatase don't develop a serious complication after a prolonged period of time. We need to find something better. So with that said, it's been used as a primary or secondary surrogate endpoint in most PSC clinical trials. So I would argue that by itself, it's a suboptimal biomarker, in part because, as I alluded to earlier, it lacks specificity. Another example is 60% of patients with an elevated alkaline phosphatase greater than 1.5 times the upper limit of normal of that particular laboratory value developed no liver-related complications after 10 years of follow-up. Moreover, having a normal alkaline phosphatase is actually pretty common in PSC. At some point, it's not uncommon for 40 or 50% of patients with PSC to actually have a normal alkaline phosphatase, and those levels fluctuate throughout the disease course, with the rate of normalizing being at about 5% per year. And when we've looked at this among our patients with PSC who live in Olmsted County over a course of about 40 or 50 years, we find that it's not uncommon that after developing a normal alkaline phosphatase, folks will often redevelop an abnormal alkaline phosphatase within 2 years' time. So it's highly variable. It's highly variable even within the individual patient. A good example of this was the simtuzumab clinical trial, which occurred over a period of 96 weeks. And when they looked at the individual patient alkaline phosphatase fluctuations during that time period, it fluctuated by an average of about 12% per patient. And despite those changes in this study, those changes in alkaline phosphatase were not associated with adverse outcomes. So again, I think we need to do better. So there's been a number of attempts at trying to better predict outcomes related to PSC. And this slide in this effort illustrates just one of those examples. And this is what we call a PSC risk estimate tool, which we affectionately named Presto. And so this was a model that was created by looking at it in about 1,000 patients with PSC. And this was created using something called artificial intelligence. The thought being, well, if humans haven't figured out much by now, why don't we give the computers a try? And what we found is that there are a number of key variables that were important in predicting outcomes in PSC that are shown here. Some of the more important ones being the serum bilirubin, albumin, the alkaline phosphatase level, and platelet count, among others. So after we created this model in a group of patients, found that it worked well, we then took another group of patients from centers all across the world and see if it worked well, and indeed it did. And what this slide is illustrating is Presto accurately predicts liver failure-related symptoms or hepatic decompensation, which means ascites or fluid in the abdomen, bleeding from esophageal varices or enlarged blood vessels, or confusion related to encephalopathy. And so Presto was able to get it right more than 9 out of 10 times, which is what this C statistic means. And that was better than the Mayo PSC risk score, the MELD sodium score, and certainly better than alkaline phosphatase in predicting this outcome over a 5-year period of time. This doesn't predict how people feel. It doesn't predict survival. It does predict liver failure-related symptoms. So what does this look like in clinical practice? So this slide illustrates what it looks like in action, and you could find out for yourselves if you so desire. There's a link that I have here, but you could access this. Anybody can access this free of charge just by entering PSC and Presto in Google, and it'll take you to this online calculator. And you could enter in your information, or your healthcare provider can help you enter in your information. And I've shown 2 hypothetical examples here. So person 1, or patient 1, is 20 years old, has a minimal alkaline phosphatase elevation. Other laboratory tests are normal, and they've had PSC for about 2 years. This would say that their likelihood of developing liver-related failure symptoms over the course of 5 years is exceedingly low, 3%. And I think it's helpful for people to see this sometimes. Contrast that to the second person who is older, has a higher alkaline phosphatase, has significant other abnormalities in not just their liver tests, but their platelets, albumin, et cetera, and have had PSC for a more prolonged period of time, the likelihood there of developing those liver failure-related symptoms is higher than the first person, as you can see here on this graph. So let's transition on to magnetic resonance imaging studies, or MRI studies, which also have diagnostic and prognostic value. There's a number of roles for MRI-based studies in the management of patients with PSC. First, if concerned about PSC, it's the diagnostic modality of choice. So doing an MRCP has replaced doing an ERCP over the past decade for establishing a PSC diagnosis involving the large bile ducts. MRI-based technologies play an essential role at monitoring for PSC-related complications, whether that may be a flow-limiting stricture, which could be causing symptoms, or investigating for the possibility of an underlying bile duct tumor or cholangiocarcinoma. It's our practice and the practice of many others to routinely screen patients for cholangiocarcinoma using MRI-based imaging studies. I often find it helpful to help triage patients who may need an ERCP, and other cases who may not need an ERCP. And it also provides what I would call a roadmap for the person doing the ERCP. It could provide a contemporary anatomical update of what the bile ducts are looking like to give insight in areas which should perhaps be sampled or looked at more aggressively, and areas which should be potentially avoided by the endoscopist so they don't cause problems. Lastly, other information can be gathered on MRI-based imaging studies, specifically liver stiffness as measured by magnetic resonance elastography, or MRE. So what do these pictures look like? So I'm sure many of you have had an MRI and may have been wondering, why am I doing this after laying in the scanner for 45 minutes or an hour? What are these doctors and other people looking at? This is what we're looking at. These are the images that are gathered from an MRCP and elastography, and let me just walk you through it. So the picture at the top left is what we call the MRCP. So this is a cholangiogram. How a cholangiogram works is it basically shows these bright areas which are bile within the bile duct, and it shows up bright because it's an area of slow-moving fluid. An MRCP does not require IV contrast to get this information, as I'm showing you here. Okay? So what we're seeing is we're seeing the main bile duct, where my arrow is. Here, this big structure, it's a gallbladder, and this is the bile ducts within the liver. And you can see in between these intervening white areas are dark areas, and those dark areas are strictures. And you can see that there are some strictures in the central area of the bile ducts, and what we call a positive arrow sign in medicine, also at this tip of the arrow, showing that in the right portion of the bile duct, there is some narrowing in that particular segment. That narrowing in that particular segment on the right side of the liver translates into other abnormalities that we see on these other imaging studies further down. You could see on these cross-sectional imagings that area which looks brighter or lighter compared to the surrounding liver does so because of underlying inflammation and scarring in that particular segment of the liver, because that's not being drained properly by that specific bile duct, which is narrowed, which is at the tip of the arrow, which I showed you. So it gives us a lot of information about inflammation, scarring, and this brightly colored picture is what we call an elastogram. So this is what we're looking at for an elastography, and this hot, bright area is a focal area of scarring in the liver, which is scarring and inflammation in the liver, which is stiffer than the surrounding segments of the liver. So this illustrates that a lot of information can be gathered from MRI-based examinations, but one thing it also illustrates is PSC is a fairly patchy disease, and that PSC does not affect the liver entirely and uniformly. So let's talk about some downsides. So being intolerant to an MRI is a real thing. It absolutely happens. Overall, fairly uncommon, at least in my experience. That's chiefly related to claustrophobia. Having an MRI incompatible device is uncommon, but does occur. Chiefly, those are going to be pacemakers and patients who are dependent upon those pacemakers. These are medical devices, and after all, an MRI is a magnet. So MRI is not an inexpensive test. It can be quite costly. And access to quality MRIs may vary across the country. Another point that I'd like to mention is the gadolinium contrast agent. I think this is important to discuss. First, I will say that you can do a good quality MRI-based exam and you don't have to use IV contrast. Okay. You could measure liver stiffness, you could get a good look at the bile ducts and not have to use contrast, but contrast does play a role, particularly if there's concern for an underlying bile duct tumor, and it probably adds to our ability to detect those early bile duct tumors, so helpful. Point to mention is that gadolinium, after repeated exposures, can deposit in tissues. That's been seen in animals and humans for a number of years, but so far there's not been any adverse clinical side effects or adverse effects seen in either animals or humans. The gadolinium contrast is cleared from the body by the kidneys, and so people who have severely impaired kidney function should not receive gadolinium. With that said, I think gadolinium use should be used selectively and in appropriate conditions and situations. So what about elastography? So I touched on this just on the other slide. There are two principal modes of doing elastography in the United States, and that's through magnetic resonance elastography and transient elastography, also called FibroScan. The concept of how elastography works, basically it involves sending a vibration through a tissue and measuring how fast that vibration goes through a tissue. That speed in which the vibration goes through the tissue is directly related to the liver stiffness. So if I were to tap on this podium, that vibration travels through this very hard podium much faster if compared I were to tap on a bowl of Jell-O. It would travel much slower. And that's directly related to the tissue property and the tissue stiffness. And tissue stiffness is a surrogate for fibrosis or scarring. But there are other reasons why there can be increased stiffness in the liver in the setting of acute inflammation, bile duct obstruction, and also other reasons such as heart failure. So this slide illustrates MRE-based technology. What we're seeing here is at the bottom, this could be done on MRI scanner with a couple added pieces of hardware and some software. It involves something called an active driver, which is effectively a fancy subwoofer. And the fancy subwoofer delivers acoustic waves into what's called a passive driver, which is a piece of rubber that's over the liver and it vibrates over the liver. During the MRI scan, the waves of vibration travel through the tissue, and that's visualized here on this displacement map that's moving. There's some areas in the liver where the waves are moving a little bit more rapidly, and the software processes that image and is able to get this stiffness map, or an elastogram, which shows that there are some focal areas of increased stiffness, but also gives a global view of the liver stiffness and the entire liver as a whole. Magnetic resonance elastography has been studied in about 400 patients with PSC. It is reproducible, it is able to predict fibrosis stage, and it is also able to predict outcomes, and that individuals with a much higher liver stiffness are more likely to develop liver failure-related symptoms compared to individuals with a lower liver stiffness. And also the changes in liver stiffness as measured by MRE also appear to have some prognostic significance and value in addition to just a single baseline measurement. So what about FibroScan, the alternative or transient elastography? So this slide illustrates what generally what the FibroScan machine may look like. And it involves a transducer that's placed in between the ribs over the liver, and there's a mechanical impulse that's delivered. And like MRE, the speed is then measured as it travels through the tissue. And like MRE, it's accurate in its ability to predict the stage of fibrosis, and it has been studied in PSC, and it's also associated with outcomes in PSC. So what about pluses and minuses between the two technology? I think they both have their own respective pros and cons, and just important to be aware of. For MRE, overall it has a lower failure rate compared to FibroScan when FibroScan is either used in other liver diseases or even PSC. The failure rate in PSC, meaning you can't get a good measurement with the FibroScan machine or the numbers are not particularly accurate, occurs at about 5 to 6% of the time. One benefit with an MRE is that it samples a much larger volume compared to a FibroScan. So let me just put that in perspective. A liver biopsy will sample about 1/50,000th of the total volume of the liver, so a fairly small fraction. And I just told you PSC is fairly patchy. A FibroScan, on the other hand, will sample about 1,000 times more volume of the liver than a liver biopsy. MRE, on the other hand, may sample 9 to 10,000 times more volume of the liver than a FibroScan, and potentially the whole liver. Doing an MRE may also detect other liver-related complications because you are able to delineate the anatomy and the bile ducts at the same time. And when doing it at the same time as doing an MRCP for another reason, It doesn't add cost to the exam or a significant amount of time. In regards to FibroScan, I think one of the chief advantages to FibroScan is it's much more widely available, I would say, than MRE-based technology in the United States, but particularly in Europe. It can be done at the bedside. So when you're seeing your healthcare practitioner or liver doctor, it can be done during that clinic visit without having to go see a radiologist. And in that situation, it's cheaper and easier if an MRCP is not having to be performed for another reason. So it appears that the appearance of the bile ducts, the appearance of the liver, and the liver stiffness are all probably important from a prognostic standpoint in PSC. And this slide illustrates an MRCP prognostic score that was developed by our colleagues in Paris. They have called the Anali score. And they looked at this Anali score and if adding liver stiffness improved its prognostic value. What does the Anali score consist of? Well, basically it involves how the bile ducts appear. It involves how the liver itself appears. So are there certain segments of the liver which are small and shrunken down, perhaps due to a severe stricture? And other factors such as presence of what we call portal hypertension or more advanced liver disease are all components of this Anali score. So the higher the Anali score, the more advanced features of liver disease and PSC are present. And so you could see here, this graph just shows the percentage of individuals who had some adverse liver-related outcome. And those who had a low Anali score and a low liver stiffness, those adverse outcomes were infrequent. However, if you had a low Anali score or a high liver stiffness, or vice versa, moderate risk. But if you have both a high Anali score and a high liver stiffness, the likelihood of developing adverse outcomes was much higher. So what I take away from this is it's not just the liver stiffness, it's not just how the liver looks or appears, it's probably a combination of multiple factors that could be assessed on that MRI-based examination. We're entering into an area and field of what I would call quantitative biliary metrics, where there's sophisticated software which is able to provide detailed measurements of the bile ducts, the bile duct volume, bile duct strictures, the number of strictures, how bad are those strictures, through software-based technology. I think there are a number of unanswered questions regarding this emerging technology, such as, does it have a prognostic value? Is it accurate? Is it reproducible? We simply don't know yet, but it's certainly understudied. So just to summarize and take things home, remember biomarkers are an objective measurement of a normal or disease process. Accurate biomarkers that could serve as a surrogate endpoint in clinical trials are absolutely essential for drug development and approval for PSC. And diagnostic and prognostic biomarkers are very useful in routine care of patients with PSC. I think some key biomarkers to be familiar with are the liver tests, such as alkaline phosphatase, prognostic scores, of which I mentioned several. Presto is one of them, MRI imaging-based technologies, and elastography. Thank you very much.
So this was a great update and presentation on biomarkers. Thank you. The next presenter is Dr. Keith Linder, who is going to talk about the landscape of clinical trials in PSC. He's the master clinical trialist. I don't think I can be a better person to tell us about where we are, where we go for this disease on clinical trials. Keith is currently the senior advisor to provost at the Arizona State University. He has long ties with Mayo Clinic. He has been the chair of our department of gastroenterology and hepatology. He has been the dean of the Mayo Medical School. He has been also prominent nationally as the former president of the American Association for Liver Diseases, chief of editor of hepatology, so many accolades. So, Keith, thank you for taking the time to come to Rochester to talk to us about clinical trials in PSC. As I said, you have done more than anybody else in that space, and we'd like to hear from you where we are, where we go. Thank you.
Thank you for the nice introduction. I was thinking earlier, the last time I think I was in this room was to hear B.B. King, the well-known blues guitarist. His most popular song was probably "The Thrill Is Gone." So hopefully you won't think that after this is over. Let's see, someone's gonna switch over for me. So I think one of the things I'll talk about is just this landscape, which I think has never been as exciting as it is. I'm sort of breaking some rules by showing several slides with more than 5 or 6 lines on them. There are about 20 drugs now that are in the pipeline, either recently reported or in the pipeline. So it's really, I think, in a very exciting time. Hopefully within the next few years, several of these will come out as being safe and effective therapies. So let's see. Okay. So what I want to show is just 3 slides. Don't try and memorize these. We'll go over all of these, some of these in detail. But this just shows the number of studies that are available. Some are older. They've been closed. We're awaiting a formal presentation of the results. Some are a little bit more recent, just becoming results known in abstract form, and some are still open and actively recruiting. So I wanted to, before starting to talk about all of these studies, we'll focus some on those that are open because hopefully these will be of primary interest to you. But I also think that in order for you to make a decision, if you're contemplating going into the trial, it's nice to know what else is available or imminently available should you decide to wait. So to try and give you, as much as I can, a clear and complete picture of what this landscape looks like. One of the things Dr. Eaton talked about was alkaline phosphatase, and you'll see alkaline phosphatase as a commonly used endpoint. It's been used for approval of drugs in primary biliary cholangitis, and even in the endpoints paper that we wrote with the FDA for PSC, alkaline phosphatase is prominent. But this shows the likelihood of normalization over the course of time of alkaline phosphatase. These are data from Mayo. One of the current fellows had put this together and shows that unlike what we used to believe, in which this was thought to be a rare event, it can happen relatively commonly. This also shows the effect, how we look at the effect of normalization of alkaline phosphatase and the association with transplant-free survival. These are data that Dr. Eaton also alluded to, but it does show that those people who have normalization do better than those in the red line that don't. This is also, on the panel on your right, shows also if the normalization is persistent, that group of patients does especially well. So that remains oftentimes one of the endpoints that are sought, particularly in shorter term trials, 1 to 2 years in duration. This is an important data from a Scandinavian study that was completed in 2005. They went back in retrospect and asked, well, does it make a difference if normalization occurs spontaneously or with drug treatment, ursodeoxycholic acid? And in the 2 upper lines are what the outcomes of people who normalized. And of course, the best were those that normalized spontaneously, but if normalization occurred with ursodeoxycholic acid, that looked to be much more beneficial clinical course than if normalization didn't occur. So alkaline phosphatase continues to be something of interest, and normalization in particular oftentimes is the goal that we would seek for a drug in a clinical trial. So I wanted to go over a few of the studies that are closed. The reason I show this is the high-dose URSO trial, and the reason I wanted to include this is not to show you so much the results, but to underscore the importance of randomized controlled trials. So if we had done the high-dose URSO trial in an open label study, liver tests would have improved. The problems that we saw, we would have attributed to the natural course of the disease. But this randomized trial showed us that, in fact, the placebo-treated patients actually did better. If we didn't have the placebo-controlled group in this study, we never would have known this, and probably all of you would be on high-dose ursodeoxycholic acid at one point, even though now, with the results of this trial, we know that that would be a bad strategy. There's another drug, ursodeoxycholic acid, that looks a lot like ursodeoxycholic acid. One of the side chains is a little bit shorter. A study with a relatively large number of patients over 2 years showed that alkaline phosphatase improved with the higher doses of the study. So this short-term study, but this is being extended, this is Michael Tronner's work in the European group, looking to see if nor-urso might be a good therapy. This shows at the highest dose about a 30% reduction from baseline in alkaline phosphatase. Many of us would like to see the percentage of normalization, because I just showed you the data about normalization, not percent reduction. Another study using a different technology, an antibiotic Xifaxan, which we use in patients with hepatic encephalopathy, done here really did not show any benefit. So even though it works well in hepatic encephalopathy as a treatment for patients with PSC, it didn't really change alkaline phosphatase values. There's another study, simtuzumab, which looked very promising. Dr. Gore has talked about the importance of fibrosis, mentioned cross-linking. This is a drug that inhibits cross-linking of the collagen, tries to keep it in the modifiable form. Sounded like a great idea when the study was designed, but unfortunately, despite great rationale, the drug was not effective, either in improving liver biochemistries or collagen. When we looked at that study at overall survival, because it was a longer study, really no differences. So this was a drug with great rationale, but not any clear benefit. One of the side effects, sort of the side products of this study, was confirmation, though, of the importance of baseline alkaline phosphatase. So those patients who had the nearly normal alkaline phosphatase levels did better than those patients with the progressively higher levels at the time of entry. So even though the drug didn't add any benefit, it helped confirm some information about the value of alkaline phosphatase and prognosis. And I think in the Presto score that Dr. Eaton just showed you, alkaline phosphatase after bilirubin and albumin was probably the most important factor. Dr. Assis talked about symptoms. One of the important symptoms is itching. This is one of the few studies done specifically to address symptoms. Maralixabat is a drug that inhibits uptake of bile acids. Thought that this sounded like a terrific approach. We know that diversion of bile acids in patients with itching, oftentimes surgically, can help. This was an attempt to do this with medication, but unfortunately it was a negative study. Maralixabat did not help the itching in this population. Intercept, which makes obeticholic acid, which is the second-line agent approved for primary biliary cholangitis. FXR bile acid has been tested in patients with PSC. 75 patients, 6 months, and it looks like it, just like nor-urso, has some biochemical improvements is measured by alkaline phosphatase. So we'll learn more about this drug. So far it's limited number, the time is short, but this looks like a potentially promising agent. There's I think it was Dr. Gore, somebody mentioned vasoactive peptides, VAP. This is a drug that interferes with that system. And this showed in a 59-patient open label study some evidence of improvement. It's just been closed. We don't have results to show you from this. So we're kind of transitioning from being able to show you results to being able to show you studies that have been enrolled patients but have been closed awaiting analysis. Bezafibrate is another drug. We've seen very promising results when used, particularly with ursodeoxycholic acid in primary biliary cholangitis, PBC. These are some of the few results that look at its value over a short period of time in patients with PSC, in which we see improvement in alkaline phosphatase while the drug is used. That's the arrow, and then the horizontal arrow, and then when the drug is stopped, the liver tests bounce back. So bezafibrate is a fibrate, something worth keeping your eyes on. And then there's another drug, cilofexor, which again looks promising. This drug is in the initial pilot studies, the phase 2 studies, looked like it improved liver biochemistries. It also had effects on some of the markers of fibrosis. And so this drug is one that's now being studied in a phase 3 or randomized trial. It's just getting started, no results available, but yet one more of these drugs that look like is going to be worth keeping your eyes on. We did a study here with curcumin. We heard Nikki Zoller talked a little bit about turmeric. Curcumin are from the same plants, but unfortunately, in this case, really saw no benefit. We previously done a study with milk thistle many, many years ago. She talked a little bit about that. Couldn't find much benefit there either. So, in fact, the one patient, it looked like one patient went up rather than down. And this again is just looking at one of the markers of inflammation. And it looked like it may have improved in the one, but not a very impressive finding. Dr. Eaton was the lead author on this paper. Then there's another study that's recently been reported. This is another one of the nuclear receptor families agents. And in this study, patients, busy slide, patients were randomized to drug or placebo. The first panel shows that there was really no effect on alkaline phosphatase, but the second panel and the third panel show improvements in markers of inflammation and a drop in bile acids. There are similar markers that show, or similar studies that show improvement in serum markers of fibrosis. And so one of the things that Dr. Eaton was talking about was the challenge of finding a biomarker. There probably isn't a biomarker. Oftentimes it will be in combination. So sometimes, and it may be that the marker chosen will differ based on the purported mechanism of action of the drug. So this becomes complicated designing these trials, and in general, we look at several things at once and then try and make heads or tails about this. So this was reported as a negative study. Alkaline phosphatase improvement was the main feature, but when they looked, they saw some of these other markers had improved, and this has piqued some interest in this as a potential way to treat. Dr. Gores talked about macrophages earlier. This drug works in that pathway. A study of only 24 patients has been completed. We don't have any results of that yet, but hopefully maybe this fall, these results will be presented and we'll know about this as yet one more potential path that can be followed. We heard several people mention fecal transplants. You may or may not have heard that 2 people died this week from fecal transplants. These were patients being transplanted for diarrheal illnesses, not for PSC, but I think we want to be cautious. There's a small 10-patient study that's been reported. Some of the patients had improvements in alkaline phosphatase, but this is, I think, way too early to see this as a mainstream treatment, and I think that the cautions that have been raised with those 2 deaths will give us pause about how aggressive to be in this approach. And then there are a number of studies still enrolling. This is a different study. The mitomycin C study is a drug, it's a cancer therapy drug that's passed into the bile ducts at the time of ERCP. This study has been going on a long period of time. You might imagine that this is a more difficult study to recruit for. And the lead investigator has left Johns Hopkins to go to China, but has assured me that someone is carrying on the work there. But this has been going on for quite a number of years. There's another metabolic pathway. It's one of the inflammatory markers, interleukin-17. So a new drug, vidofludimus, which has been used in other conditions, not ever in liver disease, is being tested. The NIH is sponsoring a trial, 30 patients, 6 months. Mayo, Rochester, Mayo, Arizona are 2 sites that are entering patients into this study. This is a phase 2. There's no placebo, but might be of interest to you. It's certainly of interest to us. And then vancomycin is another drug. I showed you the data for rifaximin, which was not effective. Vancomycin, both in series from Stanford as well as from Mayo, offers some promise. These are the data from one of the studies in adults that was done here, looking at vancomycin, 2 different doses, and metronidazole. This is looking at combined data from Mayo and Stanford, looking at the effect of vancomycin on the Mayo risk score. So this looks promising, and this also now is being a study being supported by the FDA, relatively large study, placebo-controlled trial. Entry sites are again here, Rochester, Mayo, Arizona, and Mayo, Florida. So hopefully we'll have, in a couple of years, a lot more information about this from the randomized trial. There's another study, sulfasalazine, commonly used in patients with colitis for maintenance therapy. The study originated out of Boston, 42 patients, 3-month-long study, looking to see if there will be benefit here. Just launched, don't have data from that. And then there's a variety of other studies, some of which are of interest to people here in this room. Direct has a study in PSC, which has been recruiting. High Tide, which is using a combination of berberine and ursodeoxycholic acid, is now enrolling patients with PSC. David Assis at Yale is following up on an earlier study with all-trans retinoic acid, phase 2 trial for 20 patients with PSC. A group in Birmingham, England is doing mesenchymal stem cell transplant, a fairly aggressive therapy, looking to see if this might be of benefit. And then I mentioned the cilofexor, based on the initial results of the phase 2 trial, has now been extended into a phase 3 trial to determine. Phase 3 would be a placebo-controlled trial. So at this time, there are a lot of really promising agents. We have norurso, obeticholic acid, bezafibrate, the NGM maybe, the vancomycin, the vidofludimus, and all of these new drugs that we've had. I've never, in almost 40 years of working in this area, seen a time when there are so many drugs and so many companies who have an interest in this. It just, I sort of contrast this to what I've seen in hepatitis C, in which it was 1989 before the virus was identified. But in 25 years, because I think of all of the interest, by 2014, we had an oral drug, take it once a day, any kind of patient, and cure people 95 to 98% of the time. It's my hope that now the similar attention that PSC is attracting from all of these companies with an interest in helping provide therapy will help us accelerate the progress, and so that we'll be able to be in some, not me, but someone in 5 years can talk about the great progress that's been made and the drugs that we now can choose that are helpful and effective for this condition. So I think we can conclude that there's a lot of drugs that have been tested, that are being tested. We want to be careful before jumping to conclusions too quickly, because some of the things we see can actually have adverse events. That's the importance of the careful testing. And I hope all of you use this information to help you make an informed decision about whether a clinical trial is good for you, and if so, which one you find most interesting. Thank you.
Thank you, Dr. Linder, for the great presentation. Our next speaker is Dr. David Assis from Yale University. David is an assistant professor of medicine. He's well known for his work in the space of cholestatic and autoimmune liver diseases. He's funded by the NIH to develop studies into the space to better understand the pathogenesis of those diseases. And this time, for the afternoon session, he will give us an update about partner-supported research. So, David, thank you for taking the time. Yes, this is you. This is you. This is this one. Okay, great. Thank you.
Okay, thank you again very much. It's a pleasure to be able to speak to you again. Thanks to the speakers who went before me. If you're not already excited by hearing all of that, perhaps we can bring the excitement level, as they say in Spinal Tap, to 11, because I think this is going to be kind of fun in order to just get a sense for congratulating, frankly, you and PSC partners for how much you're incentivizing and creating the spark that is really helping to drive the science and the care of patients together. I've been asked to speak about PSC partner-sponsored research, and these are my disclosures. And I'm going to just start by giving you some basics. The overall goals of PSC Partners Research Awards are to support research addressing important, novel, basic, or clinical questions related to PSC. This is the 10th year, I guess, anniversary, right, of the first awards. And so it really is a remarkable injection of energy and funds that are really necessary to bring the field forward. You can see listed there that over $3 million so far have been allocated for promising research. And frankly, I think there is also a very strong integration into the research and clinical arena in this field, which really helps to create this community energy to bring things forward. What I thought to do for this brief overview is just to give a bit of a sense for how much the PSC Partners-sponsored projects have really helped to drive a lot of the innovation that perhaps we, when we look at research and literature, almost don't realize to the degree to which PSC Partners has been behind all of this. And so I'm just going to show you a few of examples. There's many more than we could talk about in this space of grants that have been funded by PSC Partners that have then come into the mainstream of our thinking and our practice for PSC. So thank you, Ricky. This was a fun thing to put together. First and foremost, I think Dr. Lazaridis already spoke eloquently about his project, which has been multi-year. Just to highlight again that this progress study was initially, or at least in 2009, awarded as a PSC Partners grant in the first batch of awards. And I won't spend much time on this because it was described in detail, but clearly from the innovation, the effort, and the investment from the Mayo Group, along with the PSC partners, this has become a tremendous multi-year effort. And as Dr. Lazzariti said, this really translated into much more than that initial spark, but it really comes at the right time, at the right place, and the progress experience with genetics and the relationship of that to environment is a very good example, I would say, of how PSC partners came to support an idea at the right time. Moving on to another example, Dr. Linder had just spoken about the fact that there is increasing interest and now an actual full randomized controlled trial, which is going to be undergone for studying vancomycin, along with the experience, long-standing experience at Stanford. Dr. Linder was a recipient of a PSC Partners Award to look at vancomycin or metronidazole in patients with PSC. This has been alluded to in this paper once or twice already today, but once again, this is PSC Partners sponsored grants which helped to move this trial forward. And 8-10 years later, here we are at the point at which we can see a randomized trial being conducted. So once again, I think the foresight and the investment at the right time, at the right place from PSC Partners has helped to translate this idea into a stage which I frankly couldn't have imagined 6 years ago to have a randomized trial. So once again, this has been very, very helpful. Another example, which clearly has impacted the field, would be the concept of senescence in PSC. Dr. LaRusso, again here from Mayo Clinic, was a recipient several years ago of a PSC Partners Research Award. The concept, which has become very, very hot topic and heavily studied within the field of PSC and chronic cholangiopathies, is the ability, or perhaps the inability, oftentimes, of the biliary epithelium or the biliary cell to overcome a period of stress and injury, which then can lead to chronic low-level inflammation, which can perhaps be one of the main drivers of the progression of disease. Once again, this was a project which, among other sources of funding, was PSC Partners supported. Then I can tell you the impact of the concept of senescence and perhaps even senolytics moving forward in this field has been very remarkable. Heather Francis was a recipient of an award within the past 6 or 7 years looking at mast cells, which are immune cells, which are related to a concept, a molecule called histamine inhibitors. There's a very significant amount of interest now in looking at whether histamine inhibition might be a potential target in the future for therapy, not only for fibrotic diseases, but also for cholangiocarcinoma. So this award, I'm showing so far just a few of the examples of many projects that have come to fruition, are out in the literature, having an impact, which were funded directly by PSC Partners. And you can see here in this study both of the MDR2 mouse model as well as some human cholangiocarcinoma specimens that inhibition of these histamine receptors, which are thought to be highly associated with mast cells, had a significant improvement in these models and certainly would be something that could be moved forward in the future for targeting. Ulrich Boyers has had a longstanding interest in IgG4 disease, clearly separate from PSC, but highly related oftentimes, and patients clearly present with the possibility of both diseases. How to tell this apart? This was a PSC Partners grant, which was awarded several years ago, and the progress has been tremendous. PSC Partners is clearly acknowledged in this major work, not only with a new method to distinguish IgG4 disease from PSC, but what I highlighted here also is that they had elucidated the actual autoantigen, the protein which is recognized and is reacted to by IgG4, and hopefully this will lead to a new ability then to influence and perhaps better understand and treat this disease. One of the most common questions I get from patients in clinic or family members is, why don't we just do 3D printing of the livers and get this over with? It just seems like you can 3D print everything. Well, it's fair enough as a question, and we know that the scaffolding of the liver and the scaffolding of the biliary tree is something that could lend itself, in theory, to some degree of innovation from a biotechnological standpoint. So once again, PSC Partners was funding this study from Northwestern, Dr. Shah, looking at 3D bioprinting. And recent work, again, acknowledging PSC Partners, looked at some evidence that a decellularized extracellular matrix can serve as a scaffolding and perhaps something to build on for further repopulation of a sick biliary tree. It's been mentioned several times today, and so I won't belabor the point, but once again, I think there is potentially a lot to be explored under the right safety and the right settings, perhaps, for fecal transplant. But once again, PSC Partners was at the forefront of this movement, funding a pilot study, which was just accepted for publication, was mentioned just a few minutes ago. And I think that safety considerations aside, which is the foremost thought, not only by the FDA, but by investigators, getting some sense as the signal, who are the patients who are most likely to have an improvement in their alkaline phosphatase. In this study, the key findings seem to have been that there are a certain degree of taxonomic unit in terms of abundance that might predict who is to have a better response by alkaline phosphatase. An important pilot study which would not have been possible without funding from PSC Partners. Anyone who has an interest in pediatric PSC and has looked into this will probably be very familiar with Mark Deneau's recent work to put together the world's experience, essentially, for pediatric PSC. Since these are rare cases, each center might have 3 or 4 patients, but if in a group coordinated effort, a lot of progress can be made. And so once again, PSC Partners, recognizing the importance of supporting this effort, has been at the forefront of this movement. Some of the work that has been emerging from Dr. Deneau's collaborative group has really helped to define pediatric PSC, not only in terms of the expected outcomes, the timeline, the transplant-free survival, as well as even biomarkers, looking at, for example, the importance of serum GGT in pediatric PSC, all work that needs to be supported because the results are tangible and they are really moving the field forward. One study which is ongoing, awarded last year, is helping to capitalize on a very interesting and intriguing thought, which is that perhaps statins, anti-cholesterol medications, might be a potential new avenue for treatment in PSC. This is based on a smaller study which was done looking at a retrospective registry data from drug prescriptions for those who had been on statins in Scandinavia and Sweden versus not, and you can see there that there was a suggestion at least of lower all-cause and liver-related mortality. There are potentially a lot of confounders in this type of study, which led then to a request to PSC Partners to help sponsor, together with other funding agencies, a randomized placebo-controlled trial in the method that Dr. Linder was recommending, which is what needs to happen. So once again, PSC Partners is helping to fund this study, which is ongoing in Sweden, and I think we're all very interested in seeing those results. Dr. Ghulam Hussain was here earlier speaking about her clinical experience. She also is a very accomplished investigator. She is having an important role to play in understanding recurrence of PSC after transplantation. Once again, not only helping to identify various centers that can contribute to this, but looking at specific immune phenotypes. And I think this is the type of work which, for that very small set of patients at each center, needs a collaborative approach. I can tell you in my own experience the importance and the benefit of PSC Partners funding. It really can be a catalyst at the right place at the right time. Our group is looking at bile-derived organoids, so growing 3D organoids from bile collected at the time of ERCP, to see if that can help us understand the characteristics of that individual patient and perhaps give us an ability to interfere with some of the harmful inflammatory pathways which can build up between the immune system and the biliary tree in patients. There are a lot of good ideas, not all can be moved forward at different times without special push, and I think from a personal standpoint, the infusion of energy and of support can be very meaningful, so something that I think is something that all of us who've been funded and those who are doing research can appreciate very highly. So with that in mind, I'll just conclude by briefly letting you know what are the research awards that are funded for this cycle. We have a very interesting and innovative project you may want to keep your eyes on for the future for Dr. Benales, who works out of Spain, looking at metabolomic-based prediction of prognosis in patients with PSC and early detection of cholangiocarcinoma. We're not going to go into significant detail on each project, but just the essence of that is that there is new technology potentially allowing serum blood tests to give a metabolic profile between those who have PSC and do not, but perhaps just as importantly, PSC with cholangiocarcinoma or without. And their group has recently published an initial cohort characterization and some of their methods. They've made a proposal to study this with an additional center, and this was one of the proposals awarded for funding. The second proposal that was awarded for funding is by Dr. Pension in Amsterdam, looking at single-cell RNA sequencing of lymphocyte subsets and cholangiocytes in non-end-stage PSC. The simple concept is to take biliary cells and inflammatory cells from the biliary tree during ERCP with cholangioscopy and do very significant in-depth sequencing and characterization of those immune cells in relationship to those biliary cells and see how that can help us understand directly from the tissue of interest. And non-end stage means that perhaps there are changes as the liver moves toward transplant. This is attempting to understand the condition earlier on. The third award is for Dr. Oreth Weisbaum-Zinman in Israel, which is Pathways of Injury and Repair of the Extrahepatic Biliary Tree in PSC. Another concept which has been discussed perhaps and really needs an infusion of support to move forward, which is the antioxidant properties of glutathione. This has been discussed in various different forums, and the hypothesis that will be tested through this project is whether decrease in glutathione might be harmful to the biliary tree, and the converse of that is whether repletion of that can be studied. This will be through animal models and hopefully will give us a better comfort level with the role of glutathione in disease and perhaps in recovery. And lastly, a study by Dr. Roberts here at Mayo, which is genome-wide association study in biliary tract cancer. We know that cholangiocarcinoma is a rare tumor, and the association with or without PSC can be meaningful, and some of the risk factors and the genetic mutations might vary. And so this is continuation and expansion of an ongoing study, which is aiming to look at novel loci and genetic factors that could influence the risk of cholangiocarcinoma for somebody who has PSC versus somebody who does not. So in summary, I would say that PSC Partners Research Awards are extremely important, and the research support is very, very important for generating real progress in the study and care of patients with PSC. PSC Partners continues to have a very high impact in this field. It's remarkable just standing back and looking at 10 years of funding than to see the product and the things that we look at and use on a daily basis or on a research basis, which really started as sparks that were heavily supported by partners, and to see that really come to fruition. So the benefits of this funding are profound, and the first 10 years have been highly successful. So on behalf of everyone who does research and is here to support you, I want to say thank you.
Thank you, David. This is a great overview of all the awards that the PSC Partners have supported over the years. I think all of us, including myself, we have to celebrate all the support you have given us over the years. You can see the impact in many ways of your work. Thank you. It's my pleasure also to introduce the next speaker, is Dr. Veronica Miller from Berkeley School of Public Health. She's a professor in the Division of Infectious Diseases and Vaccinology and the Executive Director of the Forum for Collaborative Research. She is a leading expert of regulatory science, and the topic is PSC Forum updates and future directions. Virginia, thank you for joining us.
So thank you very much. I guess I need to. Here. Good, and thank you again for the invitation to Ricky and the board of PSC Partners. And I have to say, I hope you're just really feeling the impact of the success that you've had over the years. This last presentation was just really, really very impressive, what the PSC Partners Seeking a Cure has been able to do, and I'm very honored to be here with you today. So I'll talk a little bit about the forum, and then specifically about the PSC forum, talk a little bit about the PSC regulatory path, meaning the regulatory path for new drugs and interventions. What are some of the challenges and opportunities? I'll talk about some of the work that we're doing at the PSC Forum regarding endpoints and the role of patient-reported outcomes, and then finish up with talking about the contribution importance of patient-level data. And I always like to start off with our guiding principle, which is that once we have identified new drug candidates or therapeutic strategies, their efficient and safe development is in the best interest of all stakeholders, but most of all the patients. And I always say, I really think clinical research is not being done ethically unless it's being done as efficiently as possible. And the forum model is really quite simple. The concept is that we have one table that brings together regulators, patients, industry, and academia, and any other type of organization that's involved in clinical research. And simply by bringing everybody together in one table in a safe space, we increase the efficiency of the clinical research because there's enhanced clarity, more opportunities for innovation and collaboration, and we decrease the uncertainty by decreasing redundancy, development time, and risk. So by having regulators and patients and academicians in the industry talk to each other in an ongoing, continuous, systematic way, we can achieve that goal. And so in the traditional process, which is highlighted in this box, and this is the process, and it will continue being the process. Every single sponsor needs to communicate independently with every single regulatory agency, whether it's in the US or in Europe or anywhere else in the world. And what we do, we add to that, the forum process is we have all regulatory agencies and all sponsors in one room. So everyone is hearing the same information, and we really have information democracy in that way. I wanted to just kind of highlight all the different disease areas we work in. We started off just with HIV. We then went to hepatitis C, and that forum is now completed. We started the liver forum, which looks at non-alcoholic steatohepatitis. Then we went into, we started another forum on CMV, cytomegalovirus, in transplantation setting. We have a hepatitis B forum, and of course the PSC forum. And we also just recently launched a rare diseases forum. And the reason I'm mentioning that is because there are really synergy opportunities between these disease areas. First of all, between the PSC forum and liver forum. First of all, we have many of the same industry sponsors. In terms of topics that we're addressing, for example, in the liver forum for NASH in terms of biomarker validation, a lot of that information might be translatable to PSC as well. And I will talk about it a little bit more later, but in NASH, we're putting together a placebo arm cohort, and we want to use that same example for PSC. And one of the main issues here also is that in terms of regulatory expertise from both Europe and the US, we have the same people involved. So they're already used to talking to each other. So the liver forum has already brought them together and gotten them used to talking to each other. And that same approach can then be applied to PSC. In terms of the Rare Diseases Forum, and I do acknowledge that PSC is a rare disease, so why do we have a separate forum? The Rare Diseases Forum really looks at those that are genetically based, like Batten's disease, Fabry's, etc. And within the Rare Diseases Forum, we're really learning how do we work around the challenges of small patient populations, innovation in clinical trial design. We're talking about seamless trials, platform trials, umbrella trials, basket trial designs, adaptive trial designs, etc. And a major factor in those rare diseases is the use of natural history studies as controls so that we don't have to have placebo arms. So from both of these two forums, we can learn a lot that will benefit the PSC. So this is the basic outline of the PSC forum. We established it in 2017. You can see that we have the European Medicines Agency, the US FDA. We have a whole series of pharmaceutical companies that are members, diagnostics and other industries. And I really want to highlight PSC partners seeking a cure for their very high-level involvement in bringing the patient voice to the problem, along with, of course, PSC Partners Canada and PSC support from the UK. And we have the professional societies and other organizations involved as well. The steering committee has always, for all of our forums, we have an academic and industry co-chair, and Keith Linder is here. and we're very happy for his leadership. And Rob Myers from Gilead is the industry co-chair. You can see we have the regulatory people, we have patient advocates, the academic societies, academicians, and industry representatives. And I really wanted to use this opportunity here to really give a high five to Jessica Weber, who's our PSC Forum project manager. So last year we went through a strategic restructuring because the challenge we had, and you know, I really like Dr. Linder's lecture on the number of clinical trials that are ongoing and the number of pharmaceutical companies that are coming in. But when we first started the PSC Forum, we had, it was very few companies that were actually interested in joining us. And so what we decided to do is to synergize between the Liver Forum and the PSC Forum. So we called it a 2-for-1 membership. So companies that paid their contribution to the Liver Forum would then automatically also get to be a member of the PSC Forum. And the advantage of this was we felt it would bring more industry participation into the PSC R&D space. So I want to now acknowledge all of our sponsors. And many of you are in this room, so thank you very much. And so these are all sponsors that sponsor both the Liver Forum and the PSC Forum. And again, also, we did receive a 2-year grant from PSC Partners, so thank you very much. That was very helpful. So now to talk a little bit about this PSC regulatory path. And so the basic outcome, and this was already talked about, in fact, all of the talks preceding mine really set the stage, so I can go through this very fast. So the major outpoint we're looking for any drug development, you know, no matter what it is how a patient feels, functions, or survives. That is the ultimate reason why we're doing. We want to improve how a patient feels, functions, and survives. And this all has to do with benefit and risk. The benefit of the intervention has to be higher than the risk. It's upon the sponsor of the study or the intervention to provide convincing evidence to the regulators that they are in fact improving how a patient feels, functions, and survive. But when we look at the benefit and risk, we really have to ask, based on whose perspective? And there's not one answer for that, because sometimes some patients will be willing to take more risk than others. And so we have to be very careful how we look at that. And that's another reason why the patient voice is so important. So now we're looking at what a typical clinical trial would look like. And we called the clinical endpoints how a patient feels, functions, and survives. We often call it a hard endpoint because you either have cancer or you don't, or et cetera. So it's a very hard endpoint. But what we really need is a surrogate endpoint. And again, thank you very much for setting the stage for this, so I don't really have to go into this too much. So if we have a surrogate endpoint or a disease intermediate that predicts the clinical endpoint, then the clinical trial can be much shorter and much less costly. So that's one of the big advantages of having validated surrogate endpoint. But these have to be validated that they actually accurately predict the hard clinical endpoint, because once this is validated, if you can show a difference in this endpoint, which is a much shorter period of time, you don't have to wait for the patients to get sick, really sick. Everyone will be much better off. So what can the PSC Forum do here? What we really provide, because we work with both FDA and EMA, is this informal harmonization between the two agencies. And that in itself really increases the efficiency in the drug development process. And also what's really, really important is that we have the patient input from both sides of the Atlantic. So the key regulatory agencies we work with are the US FDA and the European Medicines Agency, and I'm very glad to see from last night that we do have quite a few Europeans here. So the EMA, as we call it, EMA, put out a guidance, a draft guidance, they call it a reflection paper, for NASH, PBC, and PSC. It has some issues. And what the PSC Forum can do, again, with input from industry, patients, and everyone that's one of our stakeholders, we can then formulate a response to EMA, because this is a draft reflection paper and they're looking for a response. And at our next larger meeting, we will spend a whole session with several of the EMA people in the room and the FDA people in the room and really go through point by point about what about this guidance would work and what wouldn't work before it becomes a final guidance. We have an endpoints working group, and our first task for the endpoints working group is to really talk about the role of patient-reported outcome measures. Again, we've had very good introduction to that, but this is a relatively new aspect of how the FDA works, and they are really looking for this input, and it's really about measuring things that are important to patients, such as how treatment will affect their symptoms, day-to-day functioning, and overall survival. And these measurements of patients' outcome provide essential information about benefits and risks of a drug. I'm not going to go into the whole development pathway, but there is a very structured, systematic way of getting these qualified and validated, which is a challenging task, but we have the various patient advocacy groups working on that. A key point that I want to make, and I will be making this several times, is higher quality data affords us increased regulatory flexibility, especially for diseases that are rare. We want regulatory flexibility because we can't have two large randomized placebo-controlled trials, one to show the effect and the other one to confirm, each with 500 patients or more, if we don't have that many patients to do trials. But the higher quality data we have, the better that data can inform the regulatory pathway. So we have the endpoints working group. We started off the patient-reported the PROMs, and we're developing a white paper, and it's being developed. Very happy to say that David Assis, Dr. Assis, is the lead author. The co-chairs are Keith Linder again, and Steve Rossi from Simabad. And we're collecting input from all the different stakeholder groups, but I thought since we're here, I would highlight what the patient perspective in this process is. And you can see that we have input from patients from all over the world, putting input into this. And really what they're stressing is the need for high quality methodology, the validity of the process and the output, the need for continuous and meaningful patient involvement. We need to reflect cultural differences. We need to find a mechanism to develop reliable and valid tools so that even though we recognize the cultural differences, we can still do multinational studies. And high quality innovative trial design, including shared placebo tools. And in this clinical trial design innovation, again, we can talk about seamless designs, platform trials, et cetera. So we're going to continue with this working group. And of course, the generation of these PROMs, that's in the hands of our very, very capable patient groups, but we will be there to assist and facilitate as needed. But then we want to continue discussion to integrate other non-invasive endpoints for clinical studies, and you've heard about some of them. Now I want to talk about the role of patient-level data. Again, I'm repeating this. The higher the quality of the data, the more regulatory flexibility we will have, because we can be more confident in what the data is showing us. And really talking about the importance of natural history cohorts. This will help us understand the patient heterogeneity, especially when we can link clinical data to biomarker studies. And that's really where we will start getting a lot of those answers. How, we can then identify predictors for disease progression paths, because not every patient has the same path, and elucidating underlying mechanisms of disease pathogenesis. But collaboration is absolutely key here, because no one can do this alone. We need all the perspectives at the table. And just something as simple from a logistics point of view, just having common data elements, for example, can be very helpful. And this will also then help us to crosstalk between randomized clinical trials and cohorts, if we can find ways to have one inform the other and really use all data to the most benefit. So the PSC Forum, we've had several calls about this already. We will support and facilitate establishing an international collaborative effort that brings in the industry and patients and regulatory perspective in the planning and execution. And as you can imagine, this is a large undertaking, and there are many groups that have already started. A group at the University of Toronto has had some major success in bringing some of the players to the table, and we look forward to working with them. And then we also want to go one step further and start collecting placebo-arm data from studies, because this can serve as a complementary, somewhat different natural history cohort, but also serve to reduce the placebo-arm burden in future trials. The fewer patients we have to have in a placebo arm, the better off we will be. And with that, I thank you, and contact me with any questions. Thank you.
Thank you, Dr. Miller. So by now, all of you know Dr. Lazaridis very well, who's moderating this session, and I have the privilege of introducing him. We've heard many of his accolades so far, but what I'll just say on a personal level, he is an individual who operates on the cutting edge on a day-to-day basis and is very forward-thinking, and I can think of no better person to give his forecast for what the next 10 years hold for patients with PSC. Costas.
Thank you for the opportunity. This is an exciting topic and a very challenging one. I know it's also late during the day, so I'll try to be brief, but at the same time, looking to your thoughts and interactions as we discuss. I think it's clear to say that the mission for all of us in this room and many others who cannot make it today or they're in other spaces is to find a cure for this disease. We have tried this and we'll keep trying until the day we find a cure to improve the lifespan and the quality of life of patients affected by this enigmatic disease. Oops. Well, we'll stay with the mission and make sure it happens, but I don't, okay, I figured out. And also, I would like to say that me as an optimist, the best way to predict the future is to create it, as Abraham Lincoln said, and I think that's the position we take for some things we try to do for this disease. We have to create all the situations that we can have a better way to treat patients with this condition. Also, 2020, I would like to say that it's a time where it's unique for healthcare, and I know there are many challenges in the space of the healthcare about cost and affordability, but I would like to focus it on the advances we have seen and we're seeing in the next 10 years and how this will play out to the benefit of understanding and treating better patients with primary sclerosing cholangitis. First of all, we have seen, and clearly we believe that there is the time frame of the empowerment of the patient, of the PSC patient, and I'll come back to this in a moment. We also see that new technology is a driving force for progress about understanding this disease and treating this disease. We now enter the space of the big data and data science, and I'll expand on this a bit. And also in the same space, if we don't have artificial intelligence, as much big data or data science we have, we're not make any progress. And I think it appears that this is one of the leads for the future. I would say that Eric Topol, a prominent cardiologist and a very prominent, influential thinker in the space of medicine, he put it right in this book. He says the patient will see you now. We have seen this day in and day out as physicians. We see patients in many spaces, including PSC, where the patients come to the room and they know a lot about disease states more than they knew 5-10 years ago because of the internet. And I think this is wonderful because if we don't empower the patients to do this type of work, we're not going to make progress. And that's extremely important. So ask questions, challenge your practitioners, because that will help them think and focus and go back and rethink about what they tell you about disease processes and disease treatments. And also challenge us. We're here, we're thinking all the time. We like to have you as partners to make us think better, make better studies. Another element that I think is relevant is that the cost and technology becomes less and less expensive and more affordable. When I was at the NIH, the cost of sequencing a human genome was $100 million, and we did 10 individuals at the cost of a few $billion. Today, you can do it for research purposes for about $150. This is tremendous. This is tremendous progress. The same happens for analysis of the exposome or the metabolome. For $100 and $150, you can identify 1 million substances into the blood. So when the cost it's affordable, actually those tests may cost these days less in a research setting than a CBC or electrolyte panel you get in your clinic. And so when the cost becomes $100 or $200, some will find a use no matter what, because this makes it affordable. And they have accuracy and validity, and I think we'll see this coming in the years to come. We now know that also we spend a lot in healthcare because of the not proper utilization of funds. We use medications for things that they don't always work the way we want, and this is probably an overexpense of about $70 billion. So if we try to do the right study, the right MRI, the right fibroscan to the right patient at the right time, that will improve the outcomes. And so, but at the same time, by doing all those things, we create an enormous amount of big data in the clinic, but also in research studies. And we have to be able now to leverage all this information we create, because I think the answer to some of the questions we're dealing with about disease progression, about disease pathogenesis, lies with understanding the big data. It tells us something there. We have to have more granular information about all these processes. And once we do that, and we're going to that direction, then we need artificial intelligence. I strongly believe in this approach. Actually, John have highlighted, and he produced the first paper ever written in the cholestatic liver literature by using artificial intelligence. Presto was based on an artificial intelligence model. And now we have another model that we submitted, another algorithm that we submitted for the ASLD. We took bile acids, simple bile acids that we studied in the clinic, and we found that they predict disease outcome actually slightly better than Presto. So there is a lot of work we can do, even with known biomarkers or known biochemical elements, that if we do it right, with the right people, we find answers. And that's the challenge, is to find the right people to do the analysis. And I know that our statistical colleagues, they know some of these methodologies, but they don't feel comfortable. Once we bring the computer scientists into the room, then they remember that they know to do some of this work, but again, it's how comfortable do they feel. At the same time, we have to educate the computer scientists who do this work. They come from another space. They come from thinking differently, which is great, but they don't understand the disease pathogenesis. We spent almost 6 months to start talking a language that we can communicate with them. And actually, my first experiment was we gave them data from about 1,500 patients, healthy in PSC, and I told them, tell us about the cohort. They didn't want to know who is the patient, who is the healthy control. We gave them data. In a week, they came back very excited. They said, we have some answers for you. I said, I'm listening. Well, they say, these people who have PSC, they have also inflammatory bowel disease, and they develop colon cancer and cholangiocarcinoma. I said, thank you very much. We know this, but this is good. You know, they didn't know who is who, and they came up with the answer. So this is remarkable. You know, today, if we go back and see what the other literature has done to the space of AI, we know that taking a simple EKG and using artificial intelligence, they can predict the ejection fraction without doing an echocardiogram. They can, computing algorithms can look into an EKG, and they can tell you about if someone has aortic stenosis. An EKG, that is all technology. So there is tremendous potential for AI. John is going to revolutionize the way we are thinking about MRI with the study that he's doing right now, looking to take AI and trying to understand what the MRI MRCP tell us about patients with PSC. So there is tremendous potential, and we'll see this outcome in the years to come. Now, as I move forward, I'm going to have a few slides to tell you how I predict to be the future 10 years from now, so 2030 or so forth. So 10 years ago, and up till today, we're using questionnaires to ask you about exposures and lifestyles. I think in 2030, we'll ask you for a blood specimen, and we'll tell you what lifestyle you had and what type of exposure you had. I think it will revolutionize the way we're thinking about questionnaires. We're not going to base our studies on bias, recall bias. Did I do that or did I didn't do it? And for many things, we're going to find, because of the affordability of this testing, we'll be in a position to tell you about your exposures and what this means to you. My prediction is by 2030, we'll have better biomarkers for PSC, and I'll expand on this. We'll have individual risk estimates for developing the disease, particularly as I'm thinking about the inflammatory bowel disease population, and I'll come back to it. We're going to be able to reclassify PSC. I think that's something that probably will happen, and I will explain why in a moment. And then we're going to have tailored therapies for patients with primary sclerosing cholangitis. So I'm going to go one by one, and I can give you my thoughts to it. Better biomarkers for PSC. I think alkaline phosphatase has a lot of limitations. Personally, I don't believe it as a biomarker. I think it will be dropped in the future. There will be a combined score that will include deep imaging, plasma biomarkers such as cell-free DNA of biliary origin and targeted proteomics, and that will be the standard of care. So take me, believe it or not, we'll come back and discuss this in 2030, but that's my vision. Individual risk estimates for developing primary sclerosing cholangitis. I think we're going to use a genetic profile once we have some more better ways to understand what this means to us, because we have a lot of data. We have 30 million markers per patient in many registries across different groups, and we have to make very good use of that. We don't have the capacity of doing it, but we will. And we'll be able to be better to have a better assessment of exposures. And we may say to patients, you have a genetic profile, you're accumulating this particular agent in your blood. That may lead to some, not good outcome, like primary sclerosing cholangitis, particularly if you have IBD. I like to start the prevention at the space of the IBD patient, because we know that the vast majority of people who have PSC, they have also IBD. So I would like to see a time when people are going to the doctor and diagnosed with IBD to start thinking about not whether you have elevated alkaline phosphatase or a liver test, but do you have exposures and genetic profile once you have the IBD to develop primary sclerosing cholangitis. That will change the way we approach the disease. That will change the way we treat this disease. Reclassification. That's my favorite slide from Minnesota with all these snowflakes. I said this before that everybody is unique, but at the same time different like snowflakes. But if you pay attention more to this slide, you realize that on purpose, I have some features that they're very subtle, but they're there. And so you have 16 snowflakes, 16 individuals. They look, all of them, like snowflakes, but in reality, if you do some individualized classification, you'll see that now the first row, they're very thin, and as you go to the second, third, and fourth row, they're very thick in their structure. And so there will be a day when patients are diagnosed with PSC, and they may have PSC-A, PSC-B, PSC-D, PSC, and the likes. And we know in the practice that there are some people who have some features like that. So we know that some young women, they have PSC without IBD and they never progress. And we know that there are some people who have PSC, which is a mild disease from the beginning, and they never progress. And we know the other phenotype, that they have advanced disease and they need transplant 5 years from now. So this reclassification will happen, but we need to have granular data to be able to inform the AI colleagues to let us help understand that better. We're getting there. Tailored therapies. I believe also that will come a point that if we identify people who have IBD, if they have a risk to develop PSC based on a combination of genetic markers and exposures, we'll tell them, you know what, you have this HLA finding that if you're exposed to X, Y, and Z, you'll create an inflammatory reaction to your bile ducts. And so therefore, try to avoid this exposure, because that will, or try to change the metabolic profile of these people. That will be one way to intervene early in the disease process before it even develops at the point that we have re-stratification, because diet-based recommendations and interactions, they're not costly, number one, and they don't pose any risk, in my opinion. We're going also to see therapies tailored to disease stage or reclassification, because we'll understand more of how this will play out. And I believe that no single drug will fit everyone. We're going to need probably a combination of some of those, because pathogenetically, there are clusters of people who behave differently, and we know this, at least from the clinical standpoint. Again, this is something that we do as we move forward. I realize that a lot of my discussion is about methodologies and approaches. In reality, though, the needs of the patients come first. This is our Mayo Clinic value statement. We realize that there will be a lot of progress. I expect so, but at the same time, the patient should be at the center, and the provider should be there to help them going through all these processes. I think the future is bright, and there is a new era that's happening, and in the next 10 years, we're going to witness that. Thank you for your time and your attention. So now with this, I would like the 4 speakers, including myself, to come to the podium so we can have a discussion and questions from you. Thank you. I'm going to start with a question. I'm going to start because I think that we're going to have a number of them. And the first one, I think, Dr. Linder, is for you. Does the benefit of NOR-URSO require that you also take URSO?
No, NOR-URSO is given independently of URSO, different than some of the other drugs such as obeticholic acid or the high tide product using berberine. Those are in conjunction, but NOR-URSO is not. That's alone.
The next question is probably, Dr. Eaton, you can help us with this. Why are bones affected in PSC, and how is bone density measured differently in young people?
Good question. So bone density could be affected in the setting of any chronic liver disease, particularly an advanced chronic liver disease, through a variety of mechanisms. One mechanism, for example, in PSC, may be a relatively higher prevalence of vitamin D deficiency, vitamin D being what we call a fat-soluble vitamin that needs bile to be absorbed in the intestine, which may be relatively deficient in patients with PSC, and that can lead to a situation where there are thinning of bones. There are other pathways and mechanisms as well in addition to that, but in terms of assessment of bone density, really the standard test is called a DEXA scan, which directly measures the bone density and gives a sense that the bones are thin, an osteopenic range, or even thinner than that, called osteoporosis.
Thank you, John. I think this is a question that probably Dr. Assis will answer. Under which circumstances would you recommend contrast during MRCP in a PSC patient? Or, yeah.
So the question is when is contrast helpful in the setting of needing to do an MRCP? The value of the contrast dye when doing an MRCP is largely to enhance the detection of an early stage cancer or bile duct tumor. And so if there is a clinical suspicion of an underlying bile duct tumor or liver tumor, it's generally advisable that contrast be administered. Contrast should not be administered if there's been a documented allergy to that contrast agent, or in individuals with severely impaired kidney function, in part because that contrast agent is cleared from the kidneys.
So then, I think Dr. Linder, we have 3 questions here for you specifically. Do you recommend using vancomycin outside of a trial? That's the first question.
At this point, I don't think we have adequate evidence to say that we should do that. There are some issues as well. Vancomycin in the oral form is very expensive. There probably are differences between formulations as far as bioavailability. And so I think just to use it because it looks promising without being in a trial, I don't think would be advisable at this point.
Thank you, Keith. So the other 2 questions for you is, can you elaborate on details of the 2 deaths from the fecal transplant and whether fecal transplant has been shown to reduce alkaline phosphatase?
So really the only data that we have is the Jessica Allerghini, who showed in 10 patients that 3 of them had improvement in ALK phos. So those were PSC patients. The patients who died, others may know more of the details, but were patients who had resistant antibiotic-induced diarrhea. So we see that in the hospital setting. Vancomycin has been an option that's been used. These patients can respond to fecal transplant. The material that they received had aggressive pathogens within it, and so those aggressive pathogens were the ones that led to the deaths. And so I think we don't really have a standardized way of providing what the specimen is that's going to be transplanted looks like. Very different, say, from liver transplantation, where the process of assessing the donor and the viability of the donor organ goes through a rigorous process of looking at it. That hasn't been done so far as part of what has been done for fecal transplant.
Thank you. David, I think you can be the best person to answer this. If you're asymptomatic, is it better not to poke the bear, or should we seek out a trial to participate in?
It's a very good question. I think in clinic this comes up all the time. I feel well, why should I be in a trial? It's a very fair point. Frankly, I think from the perspective of patient-centric care, that is the first and foremost discussion. Does a participation in a trial make sense with your life, your family obligations, work obligations? Certainly there is a strong movement also supported by PSC partners to minimize the burden on the patient to participate in trials, and that's very important. The FDA recognizes that, but despite that, there is a certain amount of investment in time and energy to be in a trial. Frankly, I think we see potential for less response. Well, it depends on the treatment, but potentially there is less response as the disease becomes more aggressive and later stage. So for a promising therapy, I have to say from a clinician or a clinician researcher standpoint that early stage may be the best time to intervene, and there's particularities of each study, but I would still encourage somebody to think long and hard about potential for early intervention and see if a trial makes sense. So whether there's symptoms or not, I think it's important. And one thing I would add, which is we sometimes have patients who would like to be in a trial, but unfortunately are too symptomatic because of strictures, need for ERCPs, and unfortunately in a symptom phase, that might actually not be the easiest thing in the world to be in a trial. So it can be a catch-22. So I wouldn't consider an asymptomatic patient to not need a trial.
John, this is a question for you. Presto calculations were developed on subjects with large duct PSC. Is it still relevant for patients with small duct PSC? And is there a better calculator for small duct disease?
Thanks. That's a really good question. So we haven't looked at Presto in small duct PSC. So with small duct PSC, we don't see the narrowing and the dilations in the bile ducts on an MRCP, for example, and that diagnosis requires a liver biopsy to establish. And it's relatively an uncommon phenotype amongst all patients with PSC, and therefore it's much more difficult to study. And so there are not real validated prognostic markers for small duct PSC. With that said, as a general rule of thumb, the prognostic outlook for individuals with small duct PSC from a liver standpoint is actually quite good and much better than large duct PSC.
So Keith, this is for you and me, and I will read the question to you. Dr. Linder, Dr. Lazaridis emphatically states that alkaline phosphatase is not an accurate biomarker for assessing the disease, yet we're using it for clinical trials as an endpoint. Who do we believe?
I think alkaline phosphatase is not an ideal marker, but we have reams and reams of data on this. My guess is if we looked at Presto, bilirubin was the most important feature, then albumin, then alkaline phosphatase. So even artificial intelligence comes up with that. I hope that there are better markers in the future. I think that also, I made a passing comment about this, but it's difficult to know how valuable, say, a 25 or 30% reduction from baseline is. Typically, when we think about it, and in the guidelines that for endpoints that we wrote, it's normalization. And I think that, I think time goes on, and these clinical trials oftentimes give us enormous information about the validity of some of the endpoints. The whole idea of developing surrogates that predict the future, is risky business, but that's what we want. Veronica pointed out that the idea of having surrogates is to try and get an answer sooner rather than having to wait for decades to see an outcome. So it's an iterative process. We do trials, we learn more about potential markers. New markers come in, those have to be validated and developed and watched over time. But I think that there isn't at any point in time a single right answer. I'll be interested in hearing what the futurist tells us.
Yeah. We'll witness that. I created this comment, and I know it creates controversy, and I like to put it there. I think it's not an ideal marker. We like to see what else we can do to improve the way we assess the disease. And in this context, I think we should look for additional markers. That's my reaction to it. So Dr. Miller, one question is about what are we doing for patients with recurrent PSC in clinical trials? Can you comment about this on your regulatory work? Is this in the frame? Like people who have recurrent primary sclerosing cholangitis.
Oh, so the question is about patients with recurrent disease?
Yes. What do we do? Do we develop clinical trials, and why
Right,
not?
yeah. So I think that's the whole issue about the heterogeneity of the disease path, which can be so different, and also post-transplantation, it can be very different. So I think the more we bring different types of people into the trials, the more we will find out. But also, I think that's why it's so important to have these natural history cohorts to really start informing the clinical trial recruitment strategy.
I wanted to make an additional comment that relates a little bit to that. I thought you might talk about this, and maybe you were alluding to it in your talk, but there is a lot of heterogeneity in PSC. Some of the work that Mark Deneau has done in kids tells us that small duct disease, about 5% in adults, is much more common in kids. Overlap with autoimmune hepatitis, 3% in adults, maybe 25% in kids. Recurrent disease, IgG4-associated disease, diseases that are a disease that may be driven by the microbiome, another that might be driven by a perturbation, a change in bile acids, all may lead to something that looks like PSC. And so I think that we've sometimes deluded ourselves by thinking it's sort of the same disease in everyone. We've heard this mentioned many times. That provides, if that's wrong, that means biomarkers are going to be different, treatments are going to be different, courses are going to be different, and I don't think that we have yet really moved our thinking into a way that we can look at this condition in that way, because we we tend to, for example, in the clinical trials that I presented to you, these are all aggregates, essentially. There's little effort to try and differentiate. So I think that's going to be another challenge for us.
So, Keith, I have a question for you then. We validated Presto. It has a value, we think, for predicting outcomes. Should we use it for clinical trials now on? Should we use Presto to stratify patients and say we're going to treat people who have a Presto expected outcome of 15 or 25%, adverse, progression or hepatic compensation, and then take this and recalculate it at the end of the trial? Is this one way to go?
It certainly is. This has been used, the Mayo Risk Score has been used for that for a long time. I showed you data from one of the studies that looked at a change in Mayo Risk Score. The MELD score, Dr. Heimbach talked about that in transplantation, has been. Presto would maybe be another one.
Yeah.
We do that for some of the patient-reported outcomes that Dr. Assis is pulling some of those data together. I think all of these things have potential value. How they will compare to each other as time goes on continues to be a source for more study as well.
Thank you. Dr. Miller, this is specifically for you. Is there a large difference in the regulatory approval between US and EMA? So if EMA approves, is that a good indication or indicator for FDA to approve?
That's a very good question, and it varies it can vary across different disease areas, but on the whole, if the data is convincing, it's usually convincing to more than one country. But sometimes there will be differences where the indication might be slightly different, the kinds of patients that a drug is approved for within the constellation of diversity of patients in a disease area. And certainly for some of the rare diseases, for example, we have seen approvals in Europe before we see the approvals here, or vice versa. So there can be a difference, but I think more and more the major regulatory agencies are really converging on what they see as convincing evidence.
I might put in a plug for the work Veronica has done, because I'm really impressed by how committed both the people from the EMA and the FDA are in trying to find solutions to this problem. We meet with them regularly, we talk to them, they're on the same page. I think that this has happened largely because of Veronica and what the Liver Forum has done. Every time they talk, I'm impressed by how collaborative they are and how similar their goals are in trying to come up with approved products that are available for this condition.
Thank you both. We have still a lot of questions, so I think unless you tell me to stop, I will continue until 4:15. The next question, David, is for you, and I found this on the table. I don't know whether it's from the previous session that you were talking or this is a new one. But the question goes as follows: is low-dose naltrexone safe to use for PSC patients? Do you feel it's helpful to reduce inflammation in PSC patients?
Yeah, I think that was discussed earlier. I don't have experience with that for inflammation itself. I think whether to use it for other indications in patients with PSC might depend on the degree to which the disease is advanced, but I don't particularly use that myself.
John, this is a question for you. Can you discuss the use of fish for diagnosis of cholangiocarcinoma, and also something relevant, do you often find cancer through CA19-9 testing?
Yeah, good question. So as it's been alluded to, cholangiocarcinoma can be sometimes quite challenging to diagnose in PSC, and that's for several reasons. Early stage bile duct tumors can look very similar to benign strictures in PSC. Another reason is this type of tumor doesn't have a lot of cells, and so it's a tumor that forms a lot of scar tissue. And so by doing an ERCP and doing brushings and biopsies within the bile duct to try to get positive cancer cells can be quite challenging, and that process alone can miss 50% of the cancers. And so because of that, there is a need for newer technologies to be developed to enhance our ability to detect cholangiocarcinoma among patients with PSC and without PSC. And so the FISH testing was one of the first steps in that arena to improve our ability to detect cholangiocarcinoma. And what that does is it looks at the number of chromosomes underneath the microscope. In the setting of cancer, having abnormal copies of chromosomes or extra chromosomes is a hallmark of cancer. And when a condition called polysomia is present, which is additional chromosomes which should not be there, that is concerning for an underlying bile duct tumor or precancerous changes within the bile duct. So not everybody with abnormal FISH test results will go on to develop cholangiocarcinoma, and how that is handled is an individualized approach. The other question related to CA19-9. CA19-9 by itself, I would say, is a suboptimal biomarker to detect cholangiocarcinoma. I say that for several reasons. One, about 7% of the population doesn't even produce CA19-9, and so we could see cases of very advanced cholangiocarcinoma, and the CA19-9 level is completely normal. Conversely, we could see individuals with PSC who had a recent episode of cholangitis, and the CA19-9 level is very high, tens of thousands, and it normalizes shortly thereafter, and they're fine and well with no cancer 5-10 years later. With that said, it's one of the tools in our toolkit, and so that is something that we at least monitor on an annual basis, or if we're concerned for an underlying bile duct tumor. Subtle elevations in CA19-9 and PSC are probably not specific. Generally, we get a little bit concerned if they're greater than 100.
Thank you, John. Dr. Miller, this is a question for you. Could you please give an example of success from PSC forum or one of the longer running forums?
There's a little bit of echo here. So a sample of success from
Sample of success from the PSC forum or in any other large running forums.
Oh, yeah, okay. So, well, I think with the PSC forum, we're really, a lot of the success is really driven by this interaction that Keith referred to. So we may not have, a major big new answer, but just the fact that all the people are talking to each other, in a consistent, continuous way, is creating the space where drug development can happen, and where sponsors are more likely to invest in this disease area if they see that the regulatory path may actually be. Excuse me. In hepatitis C, for example, we had great success in convincing everyone through this process, and it was really some of the patient advocacy groups that led this, that we shouldn't do controlled clinical trials with a placebo control or a standard of care control, which was injectable pegylated interferon ribavirin, if we're studying all oral regimen. And that suddenly the scientific concept behind it just didn't make any sense. So the FDA then said, oh, well, we know what the historic controls are, so why don't we just use historic controls? So there was randomization, but not against the standard of care. The randomization was different doses of the drugs, different combinations, different genotypes, et cetera. So that really sped up it opened up this ability to bring new drugs to market much, much more quickly, because within 8 to 10 weeks, you could show that you had sustained virologic response, which you could have never done if you had to compare it to pegylated interferon. So that's one example where both EMA and FDA were at the same table, and both were convinced at the same time that that was the path forward.
Thank you. Keith, those two questions, probably you're the best to answer. Has vancomycin been successful in PSC patients without IBD? And could you also comment on the use of statin drugs for PSC? Thank you.
We've used vancomycin successfully in patients without known IBD. Sometimes IBD can be subtle, but the Stanford pediatric practice has largely been to use patients who have both. In adults, we've used it with good effect in patients without known IBD. And Costas, remind me the second.
So about the use of statins?
Oh yeah, the
for
statins.
PSC?
So this we saw earlier Annika Bergquist data from Scandinavia. This, I was one of the reviewers of the paper, so I know it well. And I think these association studies are always challenging. If you look at your feeds that come through the news every day, association of this with that. I quit drinking diet sodas for a while because the association with memory loss, or there's an association of tinted windshields and bad driving, or something like that. I think that it poses an interesting question, but I think we need confirmation in a study that really is trying to address the value of statins. Sometimes it's these associations that lead us to the breakthroughs, but many, many times these associations are not breakthroughs. And I think it's can be a problem if people start seeing these things and just jumping to conclusions about, I'm going to do this, I'm going to do that. Nikki Zoller's talk earlier today about some of the food products may have been helpful as far as raising some cautions about what to jump into. So I think that even though there's this sense that, gee, I would rather do something rather than nothing, sometimes the something isn't good. It wasn't so long ago that we didn't use statins in patients with liver disease. In fact, it was felt to be a contraindication. I think that was overblown, but I also think that we're not at a point now, and won't be for a few years before we can start recommending statin therapy for patients with PSC.
And I would just add that the authors of that study in Sweden were aware of the fact that these associations are certainly not meant to be recommendations, which is why, getting to the earlier theme I was discussing, they appropriately sought out funding for a randomized trial, and partners, again, I think had the right intuition to help sponsor that effort, because it is very clear that the randomized trial needs to be done, and thanks to the co-sponsoring here, it is being done.
David, this question also may be for you too. For a patient with liver cirrhosis, what are the risks of developing hepatocellular carcinoma versus cholangiocarcinoma? And I suspect this is cirrhosis due to PSC.
So for patients with cirrhosis, regardless of the cause, there is a small but a noticeable increase in the risk of hepatocellular carcinoma. It is not very common in patients who have cirrhosis due to other causes to develop cholangiocarcinoma, although that can happen. But the overall risk factor, percentage of patients who develop cholangiocarcinoma in PSC can be as high as 20%, depending on how far you look into it, 10, 20, 30 years. Unfortunately, that can happen even without cirrhosis, but certainly can occur with cirrhosis itself. So for all comers for cirrhosis, it's HCC or hepatocellular carcinoma is typically 1 to 3% per year, depending on the etiology. So cholangiocarcinoma is still more common, but unfortunately, hepatocellular carcinoma can occur in a PSC patient with cirrhosis, so we need to do appropriate screening for that.
Thank you. John, this is another question for you. We understand that other than cost and time, MRE, it's much superior to standard FibroScan. So why we don't use just MRE as part of a routine test wherever an MRCP is done or not, since the additional cost is very minimal, or time?
Yeah, thanks for the question. It's a good one. And I would start by saying is we don't know if in PSC, if MRE is really superior to FibroScan. It's not been studied head to head. So we don't know the answer to that. We do know in other causes of chronic liver disease that MRE may be slightly better compared to FibroScan to predict the stage of scarring within the liver, but it's not been studied directly in PSC. And I think that would be an important study to do. I think the chief advantage of FibroScan is access and availability, but if MRE is available at your particular center and you're already having an MRI for an unrelated reason, you're right, it's much more convenient, much more cost effective, and can even save time to just do the MRE at the same time as that MRCP.
Okay, thank you. Keith, this is one question for you too. Is there any history or value of clinical trials for PSC using chemotherapy agents?
Not really. We've done studies with methotrexate that had been a chemotherapeutic agent used in the past for breast cancers and some other cancers. Methotrexate was not particularly beneficial in either PBC or PSC. Azathioprine has been tried in some small studies, not particularly beneficial. The mitomycin C, which I mentioned earlier, the infusion through a tube into the biliary system at the time of ERCP, is a study that's been difficult to enroll into. So there hasn't been a lot of activity using typical chemotherapeutic agents to treat PSC.
Thank you. John, this is for you. I think you had a paper on this. What is the prevalence of cholangiocarcinoma in pediatric PSC versus adult PSC?
So cholangiocarcinoma being diagnosed before the age of 18, so among pediatric patients with PSC, is exceptionally uncommon, exceptionally rare. Among adults with large duct PSC, as Dr. Assis was mentioning, the annual risk of being diagnosed with the bile duct tumor is highest within the first year or two of PSC being detected. And that's probably, although we don't know this for sure, but that's probably because there was an early bile duct tumor that was there that led to symptoms or worsening liver tests, which prompted somebody to seek medical attention, and therefore PSC was also diagnosed at the same time. But it's important to note that the risk of cholangiocarcinoma still persists after that year or two, albeit to a lesser degree. And so about 10, the numbers that I quote patients is the lifetime risk of developing a bile duct tumor in adults with large duct PSC is about 10 to 15%.
Thank you. Another question also for the panel is that, is pediatric PSC considered a different phenotype from adult PSC? So Keith may give us your thoughts, and then David and maybe John.
I tend to think so. I know when we write clinical trials, we tend to exclude kids, and we write clinical trials for kids we may do a companion one. There hasn't ever been a clinical trial in PSC that has included both adults and kids. And the numbers are such. You saw the data, Mark Deneau's sort of collection of all of the cases of pediatric PSC was about 800. The International PSC Study Group, largely adults, is at 10,000. And so it's, the numbers also make it problematic to do the study, but I think I mentioned a couple of the differences. The association with the more inflammatory or sometimes autoimmune hepatitis picture, the increased likelihood of small duct disease, and sometimes a transition in which patients may initially seem to have autoimmune hepatitis and then develop the bile duct abnormalities later. That's not what we usually see in adults. So I tend to think that it is different. We should think about it differently. It doesn't mean that the same treatments couldn't be applied to both, but I think it's challenging to combine them as in your thinking as the same entity.
Yeah, thank you. As we study adults, we have need to study more pediatric patients, and the numbers, it's a limitation factor. But as we do genetic studies now and exposomic studies, we like to compare those two populations if we have enough numbers, because that will be very helpful to understand the differences. And clinically, I agree with Keith 100%, they behave differently. So clinically, I believe the pediatric patients, they have probably more genetic influence because genetics always affects earlier the young people than adults, and adults are more environmental driven. I will take some questions for myself because they belong in that space. And so the first question was, does exposure to X, Y, and Z cause PSC, or could it be non-exposure to W? Yes, we know that there are exposures that associate with PSC. We also know that lack of exposure associates with PSC, and the most common one is coffee. We found this a few years ago. PSCers, they don't expose themselves to coffee. That's a negative association. I have many explanations. I think it affects the microbiome. It has been validated by the Scandinavians, I believe the study. But there are going to be many others. And actually, we have some agents, we found that they're negatively associated with PSC. So there are some chemicals out there, if you will, some substances that they are protecting patients from developing PSC. And you'll hear from us more on this. The other question was whether there is any study to assess critical events such as food poisoning and other infections of the gut and how those affect the permeability as a potential environmental trigger. The challenge with those events are very acute, and so by the time something is happening, it's very difficult to study the phenomenon in a research setting. Otherwise, clinically we don't do that, and that's a limitation. And also, and one question was for me particularly, what is the name of the test, the blood test that we study the million elements chemicals that I mentioned? This is a research study we're doing. If you're willing to participate, we'll be happy to enroll you to the study. So with this is the last question. I would like to thank all the speakers for their time and all the time they spent to giving all these great answers to your questions. Thank you for your participation, and this concludes the program. Thank you so much.
So I just want to thank all the speakers today for setting your sights on finding new therapies and an eventual cure. Your expertise and your passion sharing our mission is beyond inspiring. This is our 15th conference. It's the first time ever that medical professionals have been able to honestly give us so much hope. It means so much to us. I hope you all understand how deeply our community appreciates Mayo Clinic's unbelievable dedication to the PSC community. We are in awe. Thank you. Thank you. Unbelievable. Thank you. Seriously. Thank you.
Thank you for everything.
Oh, well, thank you. This is incredible. So now you are all free until tonight's banquet. We've had a lot of information to start absorbing, so go relax for a while. Dinner starts at 6 p.m. tonight. Please arrive in the ballroom around 5:50. Choose a table to sit with new or old friends. This will be open seating tonight. Remember to wear your camping attire. We expect to see some creativity, and there's going to be some costume judging with prizes. And then as our